Hello, Dr. Isra. Good afternoon, everyone. Am I audible and visible? So that please tell, am I audible and visible so that we can start? Okay. Okay, good afternoon, everyone. So there's thumbs up that we can start. Okay, yesterday we did molar pregnancy. First thing which I want to ask to all of you is that do you want a question session on the topic that we are discussing here after the class? Do you want a quiz like question session or a quiz like on the YouTube on the topic which we are discussing? A request was made by the students who are watching the class that they want a question session regarding the topic. Please reply in the from which video the new 16 hours rapid revision start. It has started from basic obstetrics. I am black. It has started from basic obstetrics. I think it's 3 video past. Just send a hello to me. I am black. I will send you all the videos. Okay. Please reply to this question so that I can then make questions on the topic. Do you want a question session of the top on the topic discussed in the class? Please reply. Okay, Dr. Isra is saying that he want that she wants. Dr. Isra wants. Okay, my Telegram ID is at the rate Dr. Rana Rana. I am black. You can send me your just send a hello on my Telegram ID and I will send you the relevant videos which have been done. Okay. Okay. So you all are interested. So today, once the session end after half an hour, you will get the quiz on the Telegram session. Okay. Okay, tomorrow onwards it will be just after the class. Today just give me half an hour to prepare the quiz. Okay, so yesterday we did partial mole and complete mole. Can you tell me its treatment in the three lines treatment of the partial mole and complete mole? Anyone? What were the three-line treatment of partial mole and complete mole? Treatment of partial mole and complete mole. Yes. Write down in the chat box. We did yesterday only. What are the three managements of the partial mole and the complete mole? Dr. Isra, Dr. I am Black, please write down. No, Dr. Isra, the three treatments were. Good afternoon, Dr. Ali. The three treatments were suction and evacuation, beta HCG, assessment for 6 months. Okay, beta HCG assessment for 6 months and contraception of COCPs for 6 months. So I told you that this is the complete management. Okay, it cannot be medical, Dr. Isra. It cannot be hysterectomy. Is it okay? The complete management of partial and complete mole is suction and evacuation, beta HCG, follow up for 6 months, serial beta HCG. Didn't we did it? Okay, and contraception COCPs for 6 months. Okay, this is the complete management of. What is the ultrasound picture on? Quite frequent asked question from the molar pregnancy. Main question, what is the ultrasound picture of partial mole and what is the ultrasound picture of complete mole? Can you tell me? What is the ultrasound picture of? Then we will start our today's topic. What is the ultrasound picture of partial mole? And tell me what is the ultrasound picture of complete mole? Yes, please reply. Be fast in replying. Dr. Ali, today you are silent. Good afternoon, Dr. Ali. Please reply. Snowstorm, I am Black. Snowstorm is the appearance of the complete mole. What is the ultrasound picture of the partial mole? Anyone? In partial mole, fetus was there. Anomalous dead fetus was there. Plus the placenta was making avascular villi, plus hydropic placenta. So this gives us a picture of missed abortion. Okay, what is the picture of partial mole? The ultrasound picture of partial mole is missed abortion. Are you getting it? The placenta will be of different kind, but it will be a appearance of partial mole. Okay, so quite frequently they asked you that snowstorm is found in partial mole or complete mole. So the answer is complete mole. Do you got this thing? Have you got this concept? Should we proceed? Yes, Dr. Ali. The complete mole picture is snowstorm appearance, whereas the partial mole appearances of that of the missed abortion. Okay, okay, okay. There is written. And what is the picture, ultrasound picture of choriocarcinoma? Can anyone write down? What is the ultrasound picture of choriocarcinoma? Choriocarcinoma is a malignancy. No, Dr. Ali, there is no ultrasound picture of choriocarcinoma. Okay. Cystic changes are not seen in choriocarcinoma. Choriocarcinoma is the molar pregnancy which has undergone suction evacuation, and now that molar pregnancy has become a neoplasia. So there will be no cystic changes. Okay. Dr. Ali, do you got it? Okay. Write down in the chat box answer to this question. There are multiple corrects. There are multiple correct answers. Write down in the chat box. What is the answer to this question? Write down in the chat box. This is how they give you options. They give you a picture of snowstorm appearance and then they ask you complete mole, vesicular mole. I am black has given us the options complete mole. More answers are there. Please write down. One more is correct. Dr. Isra, one more is correct. Please write down. No, that is what here I want to tell you that answer is avascular mole. Okay, the villi which are formed in the complete mole or partial mole, they are avascular. Okay, they are avascular. The villi in the partial and complete mole, they are avascular. Have you got it? Have you got it? And what is the appearance of X-ray in choriocarcinoma? That will be our today's discussion. What is the appearance of X-ray on choriocarcinoma? Okay. Okay, so that is how they give you. Mole is written in the last of every option. Okay, only difference is that we should know these three things. Yes, Dr. Ali, complete mole, vesicular mole, avascular mole. Okay, partial mole, in partial mole there is missed abortion appearance. This H mole is also right. Okay, please take a note. H mole is the another name of complete mole. Okay, H mole is also right. Okay, H mole is hydrated for mole. That is also the another name of complete mole. Okay, hydrated mole means the villi which have absorbed the water. Okay, but you're not going to mark partial mole, choriocarcinoma, vascular mole. Okay, so in all these four, one of them will be given in the option. Snowstorm appearance is found in which? So you should know all these four options. In all these are one or the another name of complete mole. Should we proceed to gestational trophoblastic neoplasia? Okay, so what is gestational trophoblastic neoplasia? The vesicular mole or the complete mole after some time can become gestational trophoblastic neoplasia, right? They can become gestational trophoblastic neoplasia when their trophoblasts keep on undergoing division. Okay, after normal delivery, the trophoblast, if it keeps on undergoing division, then it can form gestational trophoblastic neoplasia. In abortion also, if the trophoblasts keep on proliferating even after the division, then also it can form gestational trophoblastic neoplasia. So in these three cases, the gestational trophoblastic neoplasia is formed. Okay, the vesicular mole after the normal delivery, after abortion. After normal delivery and after abortion, it is a completely rare phenomena, but yes, it can occur. Okay, but yes, again, out of all this, only the choriocarcinoma questions on choriocarcinoma comes. So we are going to discuss here about choriocarcinoma. Okay, now this choriocarcinoma, the important thing about it is that it metastatize very fast. Okay, it metastatize very fast. Once the trophoblasts have become neoplastic changes, dysplasia has occurred in it, then it will metastatize very fast. Most common metastasis occurs to lungs. This question has been asked. Most common metastasis occur to which organ? Many times they have asked. A patient, Dr. Medicine is asking, a patient is diagnosed with bilateral PCOD. It is possible for her to be pregnant. Yes, Dr. Medicine, it is possible for her to be pregnant by giving ovulation drugs. Okay. Almost I am here living in Punjab. Almost 50% girls have PCOD. Bilateral PCOD. Most of them. Yes, Dr. Isra, cannonball appearance when choriocarcinoma metastasized to lungs on the X-ray. This cannonball appearance is on the X-ray. Dr. Isra, you are very right. So, cannonball appearance is the hallmark of X-ray. Okay. Okay. Lung metastasis is... Okay, that's good then, Dr. Medicine. Lung metastasis is stage 3rd. Okay, not 4th. Because the patient who has metastasized to lung that patient has good prognosis. Okay, has good prognosis. It can be treated. Okay, Dr. Medicine, my Telegram ID is at the rate Dr. Rana. Okay, you can leave your query there. Okay, so when the choriocarcinoma metastasizes to lungs, then on the lungs we get cannonball appearance. And what is the stage when the metastasis occur to lungs? The stage is stage 3. Usually when any cancer metastasizes to lungs, it is stage 4. You all know that lung is the last stage of, but in choriocarcinoma, as the treatment is very good, patient gets treated, so we have keep it in stage 3. Okay, we have keep it in stage 3 because as it get it is written here, Dr. Medicine, I have highlighted it with green. Okay, so the lung metastasize, if it is, which is its stage, this is already written that lung metastasis is stage 3rd, not 4th. Okay, so if they ask you choriocarcinoma has metastasized to stage to lungs, what is its staging? It is stage 3rd, not 4th. You are not going to label stage 4th. And if the choriocarcinoma is developing after a normal delivery, this point is very important. If choriocarcinoma is developing after the normal delivery, then it has got a worst prognosis, very bad prognosis. Patient is going to have very bad prognosis. This is what is asked, that if the choriocarcinoma is coming after abortion, after complete mole, after partial mole, then what is the prognosis? The prognosis is very bad if the choriocarcinoma is coming after normal delivery. Okay, now you tell me what is the treatment of choriocarcinoma? Write down in the chat box, what is the treatment of choriocarcinoma? What is the treatment of choriocarcinoma? Choriocarcinoma is a neoplasia, is a cancer. What is its treatment? Yes, write down in the chat box. What is the treatment of choriocarcinoma? Yes, it is chemotherapy. Cancers, yes, Dr. Isra, you are right. Treatment of choriocarcinoma is chemotherapy. No, Dr. Medicine, it is not surgery. Okay. The treatment of partial and complete mole is suction evacuation, contraception for 6 months, and beta HCG assessment for 6 months. But the treatment of choriocarcinoma is chemotherapy. Okay, we calculate the WHO prognosis score. We calculate the WHO prognosis score, and if that score is less than 7, then we give a single agent MTX, methotrexate, which is the drug of choice for what is the drug of choice for chemotherapy in case of choriocarcinoma. If the score, WHO prognosis score, is less than 7, then it is methotrexate. Okay, and if the along with methotrexate, we have also to give folinic acid. Now what they give in the option is usually they ask low scoring मतलब less than 7 वाली conditions देते हैं आपको. Usually they give the conditions in which the score is less than 7. Okay, score is less than 7, so they give you options: single single agent single agent, single dose MTX methotrexate, single agent multiple dose MTX, or 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 multiple agent chemotherapy. So if the score is less than 7 beta, then what is your answer? Write down A if it is A, B and C. Yes? Write down in the chat box. Yes, single agent, multiple doses. So you are not going to get confused with these terms, single, multiple. Okay. So along with methotrexate, we have also to supplement it with folinic acid. Okay. Okay. And if its score is more than 7, then we give the Imaco regime. Okay, we give the Imaco regime. Okay. Okay, so now here we start with abortions. That completes our gestational trophoblastic neoplasia. Now there are two types of abortions: spontaneous abortion, induced abortion. Okay, induced is the one which we induce on patient wish. Patient is saying that I don't want pregnancy, please, I don't want the fetus, please abort my fetus. So the one which we are inducing is induced. The one which occurs on its own is spontaneous. Okay, is it clear difference between? And if we are inducing any abortion, then we have to see that whether that abortion we can as a doctor induce or not. There we have to follow the MTP Act. Okay, there we have to follow the MTP Act. Got it? Okay, now spontaneous abortion. If it occurs only once and if it is occurring in the first trimester, what is its etiology? If it is occurring in the first trimester and it has occurred, it is isolated, that is occurring only once, what is its etiology? Yes? Please be active. What is its etiology? The etiology of the spontaneous abortions which are occurring in the first trimester is chromosomal abnormalities. Okay, if any abortion is occurring in the first Dr. Isra, it is chromosomal abnormalities, because when a fetus has chromosomal abnormalities, then that fetus automatically aborts. Okay, the fetus does not adopts the growth. Okay, so it aborts. So if it is occurring in the first trimester, then its etiology is chromosomal abnormalities, or you can say aneuploidies. Okay, the most common aneuploidy is trisomy. Okay, the most common aneuploidy is the trisomies, right? And which is the most common trisomy occurring? Which is the most common trisomy occurring? It is trisomy 16. Okay, trisomy 16. So there are actually many different types of trisomies. Okay, many different types of trisomies. Each we have 23 pair of chromosome. Every pair has its own trisomy. Out of it, most common is 16 chromosome trisomy. Okay, have you got it? So if we talk in general, which aneuploidy is common, answer will be trisomy. And which specific chromosomal abnormality is common? If they give you specific chromosomal, then the answer will be monosomy X. Okay, once again I would like to tell you here, if they specifically ask you specifically which abnormality is common, so answer is monosomy X. And what is the another name of the monosomy? What is the another name of the monosomy X? Can anybody tell me? What is the another name of the monosomy X? Yes? The another name of the monosomy X is Turner syndrome. Okay, the another name of the monosomy X is Turner syndrome. Okay, so if it is written trisomy 16, yes, if it is written what is the most common cause of first trimester abortion? Turner, Down, Edward, or trisomy 13. What you will mark? What is the answer to this question? So your answer will be yes. What is the answer to this question? Now they are specifically asking you, what is the most common cause of abortion? Turner, Down, Edward, trisomy 13. What will be its answer? Yes, please answer. What is the answer? So the answer to this question is Turner. Answer to yes, Dr. Ayushi, you're right. The answer to this question is Turner. It's simply they ask you what is the most common cause of what is the most common cause of what is the most common cause of abortion, and in option they are giving you trisomy, monosomy, triploidy. What will be your answer? Yes, what will be your answer? Please write down in the chat box. Yes, Dr. Isra. Yes, Dr. Ayushi. What is your answer? We can diagnose this problem by karyotyping. By karyotyping the products of conception, we can diagnose this problem. Going to the recurrent abortion. Recurrent abortion mostly occur in, yes, it is trisomy, Dr. Isra, you're right. Recurrent abortion most commonly occurs in the second trimester. Okay. Yes, you're right, Dr. Yushi. The recurrent abortion most commonly occur in the second trimester. What are the causes of recurrent abortion? Recurrent abortion, anatomical causes. There are anatomical causes. Okay, the main among the anatomical causes is cervical incompetence. What do you understand by recurrent abortion? What is the definition of recurrent abortion? 3 or more spontaneous abortion. If 3 or more than 3 abortions, spontaneous abortion has occurred, not induced, spontaneous abortions have occurred, then it is the recurrent abortion. The cause of recurrent abortion is anatomical causes. The main is among them is cervical incompetence. The second among them is uterine anomalies, the Mullerian anomalies which we had. Okay. Cervical incompetence is also known as short cervix. Now, please focus here carefully. We can diagnose this cervical incompetence even in a non-pregnant female. Right? A non-pregnant female can also come to you that I had 3 abortions and in the second trimester, what can you do? So you can diagnose even in a non-pregnant female. What test you do in a non-pregnant female is you pass number 8 Hagar dilator in the cervix, and if it is passing smoothly, then it means that its cervix is loose, its cervix is incompetent. Okay, its cervix is not capable to hold the fetus. Right? The another test which you can do in a non-pregnant female is hysterocervicography. Okay, this test is usually not done. Usually what is asked in your exam is number 8 Hagar dilator. Okay, number 8 Hagar dilator. Now please think, if it is written in exam that a pregnant female is coming, can you pass such a Hagar dilator is like this pen, such a thick it is. Can you pass such a thick dilator into the pregnant female uterus? No, you cannot pass. Right? So in a non-pregnant female, the test is passage of number 8 Hagar dilator, or you can say passing of Foley's catheter number 12. In pregnant female, the diagnosis of choice is transvaginal ultrasound. Both are asked. Again, I am telling you, both are asked in FMG also, in other exams also. In the pregnant female who is coming with a history of 3 or more abortions in the second trimester, then if the lady is pregnant, then we cannot pass the Hagar dilator. Then we have to do transvaginal ultrasound, and if the cervical length on the transvaginal ultrasound is less than 2.5 centimeter and there is formation of shape like Y, V, U. So how you will remember T, Y, V, U? Trust your vaginal ultrasound. Okay, normal shape is like T shape. Okay, normal shape is T shape. Okay, so this is T, you can see. Right? And if this cervix gets incompetent, then it forms a Y. Then it forms the Y. If it gets more incompetent, then it forms the V shape. Okay, and if it gets open, if it gets dilate, then it forms the U shape. So how you are going to remember it? Trust your YOUR, your vaginal ultrasound. Okay, so which is the, write in the chat box, if a pregnant female is coming to you with a history of recurrent abortion, what is the investigation of choice and what is the investigation of choice in non-pregnant female? Okay, write down in the chat box. If now, what is the treatment we give to that lady? We give, what is the treatment we give? We give cervical encerclage. Okay, we give cervical encerclage. We tighten the cervix. We put a suture in the cervix. Okay, yes, Dr. Isra, you're right. So what are the surgeries which we do? Okay, the surgeries electively which we do is McDonald's, Shirotker, or laparoscopic. Elective surgeries are McDonald. McDonald is the most common cervical encerclage we do. The another is Shirotker. The last preferable is laparoscoping. But if a lady is coming to you, yes, in the non-pregnant, you're right, Dr. Isra, it is passing the Hagar dilator number 8. Okay, in a non-pregnant female, we will diagnose it by passing Hagar dilator number 8. And if a patient to coming us in with emergency, if a patient is coming to us with emergency in this U shape, we did an ultrasound and we find that the cervix was of U shape, then what all we will do? We will put a cerclage in emergency, and the name of that cerclage is Benson and Broom. Please learn this name. These days lot of questions are being asked on cerclage. What is a cerclage done in the case of emergency? It is Benson and Broom. What is the contraindication of cervical encerclage? If the patient is already in labor pain, then we cannot put in the cervical encerclage. Only we are going to put if the patient is not having true labor pains. Then only we can put cervical encerclage. Okay, we cannot put cervical encerclage if the patient is in labor. Okay, so what are the contraindications are? Strong uterine contractions. Okay, if there are strong uterine contraction, it tells us that patient is in labor. Bleeding or infection, bleeding or local infection, if membranes are ruptured. Okay, and we all do this procedure to save the fetus, isn't it? We do this procedure to save the fetus. So in the case of fetal death and fetal anomaly, we are not going to put the cervical encerclage. Okay, we are not going to put the cervical encerclage if the fetus is dead or fetus is anomalous. Then it is good if the delivery is occurring, right? What is the contraindication of cervical encerclage? Strong uterine contractions, bleeding, infection, ruptured membranes, or fetal anomalies. So this was the question of NEET PG 22. NEET PG 22. If membranes are ruptured, will you put or not? Okay. So let us discuss now the other cause. Main cause we have studied, how we will diagnose, and what is the treatment of cervical incompetence we have studied. The other cause of the recurrent abortion is uterine anomalies. How we diagnose that we all will study in the Mullanian anomalies. The various uterine anomalies are unicornuate, bicornuate, septate, uterine diadelphus. Okay, so we will diagnose it by hysteroscopy and laparoscopy. The best diagnostic tool is hysteroscopy and laparoscopy. We can also diagnose it by MRI or 3D ultrasound. Okay, but HSG is least preferable. On this line, 3 times question have come in your post-grad exams. Okay, that we diagnose the various uterine anomalies by hysteroscopy and laparoscopy, right? By putting the scope and seeing with our eyes what problem is there, whether there is septa in between the uterus, whether there are two uteruses, what is the problem. And we are only going to do the surgery only and only if it is a case of habitual abortion. Okay, and we will only going to do the surgery in a patient of unicornuate, bicornuate, septate and uterine diadelphus, that if there is a habitual abortion. Habitual means recurrent abortions are occurring. Recurrent abortions are occurring. What is the surgery which we do for unicornuate, bicornuate and uterine diadelphus? Their uterus wall is in between. So the surgery which we do is metroplasty. And the surgery which we do for the septate uterus is septal resection. Hysteroscopic septal resection. The surgery which we do for the unicornuate, bicornuate and uterine diadelphus is metroplasty. Metro means uterus plasty. Okay, because in between there is uterus wall. So we have to take out that wall and then do the surgery. In septate uterus there is no uterine wall. There we have to cut the septa. So the answer is septal resection. Okay. The second most common reason for the recurrent abortion is Appla syndrome. What happens in Appla? That antibodies are formed. Okay. Antibodies are formed against the phospholipids. Phospholipids are present in the cell membrane. Phospholipids are present in the cell membranes. Okay, so phospholipids are present in the cell membranes. Antibodies are formed against the phospholipid. And what is the name of that antibodies? Lupus anticoagulant, or you can say Appla. These are different. Please note down that its name is anticoagulant, but it increases coagulation. Okay, and Appla is also formed. So these are the two antibodies which are formed. Now what they do, they prevent the physiological changes in the decidual vessels, and in the spiral arteries they cause thrombosis, which leads to IUGR and subsequently fetal death. Okay, so what happens in Appla? In Appla, due to formation of these antibodies in the spiral arteries, thrombosis occurs, which lead to less perfusion of the less oxygenation of the fetus blood, and in all it leads to fetal death. Okay, history. What does the patient gives you history? Who is having Appla syndrome, that is in which the thrombosis occurs. It gives you a history of recurrent abortion, right? It gives you a history of IUGR, intrauterine death early. Because of that thrombosis, preeclampsia occur, and because of preeclampsia, abruption occurs. Okay, so is it clear to you what is occurring here? Okay, is it clear to you? So basically in pregnancy, what the patient gives to you in history, pregnancy related histories, that recurrent abortions are occurring and IUGR is occurring and intrauterine death occurs. And in pregnancy I had preeclampsia, abruption. So these all are the indication that occurs. In what are the history given in the patient when the patient is not pregnant? Recurrent thromboembolic episodes. Okay, recurrent thromboembolic episode. What is its treatment? What is the investigation? The treatment of this condition is APLA or APTT. Okay, APLA. The treatment of investigations which we do is we measure the APLA antibodies and APTT. Okay, artificial APTT and APLA. And what is its treatment? We give preconceptionally, we give if aspirin. These both APLA and APTT, they are raised. Okay, prothromboplastin time. Okay, and preconceptionally when the patient thinks of becoming pregnant, we give aspirin, and once the patient becomes pregnant and fetal heart rate comes, then we give low molecular weight heparin. Low molecular weight heparin. So question have been asked on the history, what test we undergo if the patient is giving you a recurrent history of abortions, preeclampsia, then what test you will ask the patient to undergo? The test is APLA and APTT. And what will the treatment give you? We will give aspirin preconceptionally and low molecular weight heparin in the case once the fetal heart rate comes. Now let other causes of hormonal causes of abortion are luteal phase defect, hyperprolactinemia and hypothyroidism. Okay, and infections which are responsible for abortion but they are not responsible for recurrent abortion. They are torch, isolated torch. Now this is a very important information which we quite frequently do mistake, that torch is responsible for abortion only once. For if torch infection occurs, then antibodies are produced in the body and it does not lead to abortion next time. Okay, so this is very important information. Quite frequent you do wrong in quiz, that due to torch recurrent abortion occurs. No, due to torch infections, if abortion has occurred once, then very soon till next pregnancy the immunity comes, right? Similarly, as the syphilis follow the Kasowitz law. What is Kasowitz law? That period of gestation increases with each abortion. For example, if abortion has occurred once in the first trimester at around 11 weeks, then next time the abortion will occur around 20 weeks, and the third time the abortion will occur in the 30 weeks. Okay, such a gap is it. Each time the period of pregnancy will increase, and the next time the fetus will be delivered live. Okay, so it is asked that in Kasowitz law is for congenital early syphilis, congenital early syphilis, congenital late syphilis, or for other. So the answer to it is the Kasowitz law is for congenital late syphilis. Okay, the Kasowitz law is for congenital late syphilis. Okay, because period of gestation increases. So this question has been coming from last 2-3 years repeatedly, that torch causes isolated abortions. Torch does not cause recurrent abortion. Syphilis not cause recurrent abortion. Okay, both torch and syphilis, both of them, they do not cause recurrent abortion. Syphilis does not cause, because syphilis follow Kasowitz law. Okay. Now, what is blighted ovum on ultrasound? Blighted ovum means that only gestational sac is formed. No fetal pole is formed. Okay. What is blighted ovum? Blighted ovum means no fetal pole, only gestational sac is formed. And what is missed abortion? Missed abortion means that pregnancy started but it get terminated in between. But soon the pregnancy stops, its growth stopped in between. So blighted ovum is also a type of missed abortion. Okay, blighted ovum is also a type of missed abortion. So what is missed abortion? Missed abortion means once the pregnancy occurred, but soon the pregnancy growth stopped, get interrupted in between. Okay. And the missed abortion in which not even a small fetal pole is formed, that is known as the blighted ovum. The early missed abortion is known as the blighted ovum. Okay. So clinically, in every abortion, pain and bleeding is present. Okay. So what are the clinically different types of abortion? So first of all, when abortion occurs, then bleeding occurs, right? And the cervical os is closed. Okay. Slight bleeding occurs and the cervical os is closed. Okay. So that stage in which the cervical os is closed and the only slight bleeding occurred and uterus height is equal to the period of gestation. How you will come to know that only bleeding is occurring? If the uterus height is equal to the period of gestation. If you are doing the PV and finding that uterus height is also 8 weeks and period of gestation is also 8 weeks. So then only you will say that no loss has occurred, right? Only bleeding has occurred, no loss has occurred, and os is also closed, right? And what is the treatment of it? That we will get the ultrasound done to get for the fetal heart rate, and we will give the patient progesterone. Okay. In case of threatened abortion, we get the ultrasound done for fetal heart rate and we give the patient, and if fetal heart rate is present or all gestational sac have not fetal pole is yes. No dear, only if the Dr. Isra has said that every gestational sac who does not have fetal pole is blighted ovum. No, Dr. Isra, there is a parameter that after 5 mm gestational sac, if fetal pole is not coming, then only we will say that it is blighted ovum. Is it clear? Only if the gestational sac is more than 5 mm, still fetal pole is not coming, then this is the criteria. Okay. So incomplete is now the os has opened. Now cervix and the uterus has gone under contraction and the os has opened. Because os has opened, right? So now it is impossible to prevent this abortion. Even if the uterus size is same as that the size of the period of gestation. Even if the uterus size is same that of the period of gestation. But if os has opened, it means that now we cannot prevent this abortion. This is very important. Inevitable means that abortion process has gone up to that extent that we cannot stop it. Os open and now the treatment is DNC because now we cannot prevent it. The treatment is DNC. Okay. Why inevitable? It is inevitable once the os is open, because see, uterus has contracted a lot, right, to open the os. So uterus has undergone all the changes such that the os has opened. So it is not a small thing that os has opened, right? Uterus has undergone changes that the os has opened. What is incomplete abortion? Incomplete abortion means that something has passed out of the, this is the next stage, that out of the opened os something has passed out. So of course now the uterus size will be less than period of gestation, and uterus height will be less than the period of gestation, and of course the PV will be, os will be open, and patient will give you a history that something has come out from my uterus. Something has come out from the vagina. Some pieces have come out. The treatment of it is DNC. What is left, we have to remove it. Right? And what is complete, the uterus becomes as a non-pregnant uterus. Everything which was inside has came out. Everything which was inside has came out, and now the os has closed, because os only opens to get something removed from the uterus, because everything has gone out. Uterus has become at the height of non-pregnant uterus, right? Uterus height is like a non-pregnant lady uterus. Everything has gone out. So now the os will be closed and no bleeding will be there, right? So now no treatment, only assurance. We just have to tell the patient that you have conceived and now nothing is left, and just plan for your next pregnancy after 3 to 6 months. Okay, now what is the MTP Act for the abortion? That is the induced abortion. Okay, we have done with first trimester abortion, second trimester recurrent abortions. We have done with the missed abortion and clinical types of abortion. Now we are doing with the induced abortion. Okay, so what is the indication when a patient will come to you, doctor, abort, I don't want. Okay, and this law has undergone some amendment in 2021, and there were amendments in 2021. So lot of questions are being asked from this slide. It is very important, please listen carefully. Okay, see, first of all, there are 4 indications on which you will do abortion. Okay, these indications were previous abortions indication only, but you should know. Patient will keep on requesting that, Doctor Saab, you do my abortion, it is unplanned, but you will do abortion only on these 4 indications. Number one indication is that if that lady gets pregnant, then mother life is in danger. Okay? If that lady gets pregnant, then mother life is in danger. Pregnancy is fatal to mother. Okay? Next is that the fetus has such an anomaly that it is not possible to survive. Okay? Fetus anomaly. Number 3, if it is a case of sexual assault. Number 4, if it is a failure of contraception. Okay? Yes, it can be stage 3 or 4 heart diseases. It can be Eisenmenger syndrome. It can be pulmonary hypertension. Today we are going to do that list. Time period is what have changed or amended in 2021. Soon we will discuss. But there are 4 indications for abortions. Okay? If the pregnancy is fatal to mother life, if the fetus has got such an anomaly that fetus cannot survive, if it is a case of a sexual assault, and if there is failure of contraception. Okay, all the abortions can be terminated up till 20 weeks by the permission of one registered medical practitioner. Okay, Dr. Isra, in all the four indication, one registered medical practitioner, with the sign of one registered medical practitioner, we can abort the fetus up till 20 weeks. Okay, and 20 to 24 weeks, we need permission of two registered medical practitioners for maternal diseases, sexual assault and fetal anomaly, but not for failure of contraception. Okay, not for failure of contraception, only for these three problems: maternal diseases, sexual assault and fetal anomaly. Okay, can be aborted till 24 weeks, from 20 to 24 weeks, by the signature of two RMPs. Okay, RMPs, registered medical practitioners, who has done MD Gynae, who is DGO, okay, or who has got the license from the government after MBBS. That is registered medical practitioner whom the government has registered for doing MTPs. Okay, they are basically the one who has done post-grad in Gynae, or one who has done the house job in Gynae and has been registered by the government of that state. Okay, and the very important, why this law was amended in 2021, very important, please listen carefully. This law was mainly amended for fetal anomaly. Okay, this law was mainly amended for fetal anomaly. Fetus anomaly can be aborted at any time, but after 24 weeks a board will be formed. Okay, even one can abort its anomalous fetus at 9 months also. Okay, that fetal anomaly can be aborted up till any time, but after 24 weeks a board is formed. Okay, is it clear to you, Dr. Isra? RMP is clear to you? Okay, so these are the three steps they are continuously being asking in the exams. Okay, for the failure of contraception, MTP can be done only up till 20 weeks. Okay, and only one registered medical practitioner is required. From 20 to 24 weeks, only for these three indication you require, you can do MTP. Board is formed, matlab 3-4 persons are constituted. In this board, there is one is pediatrician, one is gynecologist, one is radiologist, and number 4 is a member from state board. Member from state. Okay, so these 4 persons, they decide. Not only 2 RMPs decide, these 4 persons will decide that whether this anomaly is really a candidate for abortion or not. Okay, so fetal anomaly can be aborted unlimitedly, but after 24 weeks board is required, and from 20 to 24 weeks no contraception failure is aborted. Only maternal diseases, sexual assault and fetal anomalies are aborted by the signature of 2 medical practitioners. Okay, now what are methods of abortion? These are also asked. Up till 9 weeks. In India, the permission is only for 7 weeks. Up till 9 weeks, we can abort it medically by giving medicine. Mifepristone 200 mg is given after 48 hours. After 48 hours, then we give after 48 hours, then we give if 800 microgram mesoprost. Then we give 800 microgram mesoprost. Okay. So what are the drugs which we use? Yes, up till 9 weeks, the drugs which are used is mifepristone 200 mg. After 48 hours, after the gap of 48 hours, we give mesoprost 800 microgram. Okay. If the pregnancy is of very less period of gestation, that is if the pregnancy is less than 7 weeks, then we can also give mesoprost 400 microgram. Okay. What is the function of the drug mifepristone 200 mg? It kills the fetus because it is anti-progestin. It kills the fetus. Mifepristone is an anti-progestin. It kills the fetus and then it separates the placenta. Is it clear? It kills the fetus and then it separates the placenta. And tablet mesoprost, prostaglandin, it contracts the fetus and it expels the killed fetus. Is it okay? Is it okay? Clear? Okay. Now the tablet mifepristone is basically an anti-progestin. Now if it is a second trimester abortion, then it means that the pregnancy is of much more period of gestation. Right? Now what we have to do, we have to ripen the cervix. We have to make the cervix soft. Okay. We have to make the cervix soft. So first we have to give, in the second trimester, first we have to give prostaglandins. Then we have to, after the softening of the cervix, then we will, from the soft cervix, we will take out the pregnancy. Right? Okay. Now the tablet mifepristone 200 to 600 mg is given in second trimester. What is the dose? Tablet mifepristone 200 to 600 mg followed after 48 hours. After 48 hours, then we give mesoprost or 400 microgram 3 hourly 5 doses. Right? Are you getting my point? After giving the mifepristone 200 to 600 mg, depending on the period of gestation of the fetus, then we will give tablet mesoprost 400 microgram 3 hourly 5 doses. This was the question of August 20 FMG. Okay. If the fetus is already expired, if the fetus is dead, right, it is a case of intrauterine death or missed abortion, then we will give tablet mesoprost 800 microgram vaginally followed by same that tablet mesoprost 400 microgram 3 hourly 5 doses. Because the function of mifepristone is to kill the fetus. If already the fetus is a IUD, it is a missed abortion, then no need to give mifepristone. Give mesoprost 800 microgram vaginally. Okay? Okay. Now, instead of mesoprost, you can also give dinoprostone and you can also give PGF2 alpha. Okay? Instead of mifepristone, you can also give dinoprostone and you can also give PGF2 alpha. What are the surgical methods? Right? The surgical methods by which we can abort the fetus or by which we can take out the fetus outside is manual vacuum aspirator, MVA syringe. Right? We can also take it by electric vacuum aspiration. We can also take it by manual vacuum aspirator. Okay. The capacity of MVA syringe is 60 ml. The capacity of MVA syringe is 60 ml. The pressure which is built up inside is 600 mmHg. Okay. And we can abort the fetus up till 12 weeks. This 12 week is very important. Okay. And yes, it is a very comfortable OPD procedure. Patient is very comfortable by it. It is a OPD procedure. Have you got these things? The preferred surgical method is suction. Suction can be done by electric suction or manual vacuum aspirator. The pressure built up inside it is 600 mmHg. Up till 12 weeks, it can be aborted, and its capacity is 60 ml. Okay, we can also do DNC, but DNC is not considered a good method, because in it we have to give GA and cost also increases, and lot of complications are also with DNC. Okay, so it is it. And what are the other second trimester methods? One is ripening of cervix can be done by laminaria tent, which is basically a seaweed. Okay, laminaria tent is basically a seaweed. Another name for it is dilapan, right? And we can also do hysterotomy, which is basically giving an incision on uterus. Okay, and intraamniotic, we can put a hypertonic solution, saline, urea or mannitol, which also induces pain. And extra amniotic, we can also use ethacridine lactate. Okay, is it clear to you? These are some special second trimester method. You should be very familiar by this method, because these days they have been asked in INS at November that ethacridine lactate is used in first trimester or second trimester. So you should know all this. The question can come in your FMG. Okay, hysterotomy is just like cesarean, right? And laminaria tens, dilapan is for cervical ripening. Okay, now please see these images. Please see these images. This first image is of MVA syringe. This is MVA syringe. The second image is of ovum forceps. This is used to take out the products during DNC. This third is the Carmen cannula. This we put in the front of MVA syringe. And if the pregnancy is of 8 weeks, I told you in MVA syringe we can terminate it up till 12 weeks. If the pregnancy is of 8 weeks, then 8 number Carmen cannula will be used, right? And this number 4th is curettage. Curate. Number 4th is curate. Yes, Dr. Isra, you are right. Number 4th is curate. Number 5 is Hagar dilator. Okay. Dr. Isra, number 4 is curate. It is curate. We do DNC. We do it with the help of curate. Have you got it? These are various Hagar dilators. Number 6 is Alice forceps. This has got very good grip. It is used to hold any tissue. It has got very good grip. You can see this has got very good grip, right? Alice forceps. Number 7th is Sin speculum. since speculum. Okay, I'm taking here 10 minutes break. I will be back after 10 minutes. I have got a emergency call. That's why I will be back after 10 minutes and we will be doing teratogenic drugs, medical diseases and infection. Yes, Dr. Isra, it is Alice forceps. I will show you in the next class. I will show you difference between Valsalem and Alice forceps. Okay.